So now this is just an demonstration of what we have learnt before. So you can see the droplets from the cough or the sneeze by the infected persons. The Mycobacterium tuberculosis goes inside the alveolar macrophages. Now what happens, the additional, there will be a cytokine as well as additional phagocytic release will be present. Certain Mycobacterium tuberculosis will survive and they will go and infect and cause primary infection. So they can go and infect the various distant organs and they cause primary infections like cough, chest pain and weight loss. Now what happens, again they are going to go and form the granulomas around 2 to 8 weeks, and there's going to be, this is the latent TB. So effects of pregnancy on tuberculosis. As such, pregnancy doesn't increase the susceptibility to TB infection. That is one point you have to keep in mind. Or it also doesn't increase the progression of latent TB to active TB. So as such, pregnancy is not going to increase the risk of tuberculosis. Pregnancy also doesn't affect the susceptibility to a particular site for TB infection. However, pregnancy can make the diagnosis of TB more difficult because this fatigue, all this malaise, shortness of breath. So all these symptoms can be present in a normal pregnancy also. So it makes diagnosis of tuberculosis even more difficult. A higher incidence of TB is seen in the postpartum period. So why does the higher incidence of TB is seen in the postpartum period? Because in pregnancy or in the antenatal period, what happens is that there is suppression of the T cell activity. So as such, there's suppression. So what happens once everything is settled in the postpartum period, when all the immunogenic phenomenon becomes normal, the higher incidence of TB disease will also be is seen reported. Now moving on to the effects of tuberculosis on pregnancy. There is adverse maternal and neonatal outcomes are increased. Maternal and perinatal outcomes are consistently poorer with active TB. If you don't treat the active TB, it is going to the outcome is also going to be worse. Antenatal admission is more, maternal anemia is more. The risk of untreated active TB disease on the pregnant woman and the fetus is greater than the risk of treatment. So if you don't treat, the risk is going to increase. For example, if you don't treat the tuberculosis in the pregnancy at the correct time, it will actually increase the maternal morbidity by 3-fold. There is 9-fold increase in miscarriages. There is 2-fold increase in preterm labor, and there is 6-fold increase in perinatal mortality of the fetus. So hence TB, the treatment of TB should be done at the correct time to prevent all these complications. So the present day scenario says that tuberculosis has re-emerged. So it has re-emerged as one of the most important diseases. It's because of the following features. One is HIV is on the rise. The second is multi-drug resistance has been increased due to the misuse of antibiotics, poverty and malnutrition, population explosion, lack of access to good health care, and false sense of security due to chemotherapy, influx of younger people from foreign countries. So the perinatal screening of tuberculosis. So now, is screening of tuberculosis necessary in our country? So when you see in our country, there's high incidence of tuberculosis and we all would have got a BCG vaccination. So generally there is no role for screening in our place because the incidence of immunoconversion is very high. That is, the positivity of a tuberculin testing is very, very high in our country. So hence prenatal screening, what the WHO says is that prenatal screening can be useful in developed countries or countries where the TB burden is low, so that you can find out who and all are positive to the tuberculin testing, and you can treat them with isoniazid prophylaxis to prevent the mortalities and morbidities. But in our country as such, doing a tuberculin testing in pregnancy or giving an isoniazid prophylaxis for tuberculin positivity is not recommended because we all know the risk of immunoconversion is very high due to the increased burden of tuberculosis. So that is what they say. In countries like India with high incidence of tuberculosis, exposure and infection, universal BCG vaccination, there is no role of screening since the incidence of immunoconversion is high. Since the incidence of TB is high, the BCG vaccination also we give for everyone. So the tuberculin testing also, positivity is also high. So it can be done in countries where the TB burden is low. So the RNTCP recommends that all pregnant women undergo symptom screening at every antenatal visit since this provides an opportunity to screen for pulmonary TB and facilitate early diagnosis and treatment. That is what RNTCP in our country, it actually stresses on the fact that each and every woman should be screened, should be symptom screened for tuberculosis. If they are having any symptoms, we have to refer them to the correct DOTS program so that the mortality and the morbidity can be decreased. One study includes only HIV positive. So there was a study which included only HIV positive, and they found the TB prevalence. And in that study, they found the TB prevalence is around 1.4% for all HIV positive people. So that clearly indicates that it's always better to screen HIV patients for co-infection with tuberculosis. So patients who are at the risk of exposure to tuberculosis are, as I told, immigrants, homeless people, medically indigent residents, so who can't afford proper medicines, intravenous drug users, healthcare workers. So patients who are at risk of disease once infected. So the risk of major morbidity is high if they are co-infected with HIV, malnutrition, medical illness, and infants. Universal screening of all women prior to or during pregnancy would be ideal, but it is virtually very impossible because we don't normally do it. So we don't screen for TB as such in all antenatal visits, but it is. So now the studies are telling that it's better to screen for patients, symptom screen the patients so that we can diagnose it at the earliest. So screening. So what is the screening? This is also called as the Mantox test or the tuberculin testing. So what we will do is, we will inject 0.1 ml of PPD, which contains 5 units of tuberculin. So we'll inject 0.1 ml of protein part derivative, which contains 5 units of tuberculin, into the dorsal forearm, and we will wait for 48 to 72 hours and observe for induration. So we will look for the induration. So you can see we will look for this induration and we'll measure the induration. So any induration which is more than 15 millimeters, it's considered to be a positive tuberculin test. But there are conditions where an induration of more than 5 millimeters can also be taken as positive, and there are conditions where more than 10 millimeters also can be taken as positive. And when you see when the induration is less than 5 millimeters, then they are tuberculin negative. So interpretation, as I told you, more than 15 millimeters is a sure shot diagnosis of tuberculin test positivity. But there are certain conditions when induration of more than 5 millimeters can be considered as positive. So what are the conditions? Number 1, in HIV patients,